It's lovely to see you all here, particularly on a cold winter's night. It's hard to get Perth people out on the midweek in the cold winter, so thank you for being here. Really appreciate it. My name's Julia. I'm one of the naturopathic medicine practitioners here at Remede, and I wanted to start with just a brief acknowledgement of country. So acknowledging the traditional people and healers of the land on which we gather today. That's the Whadjuk people of the Noongar Nation. I'd like to pay our deepest respects to their elders, past, present and emerging, and we honour their connection to the therapeutic power of plants, land and community. So I'm super excited to be here tonight and hosting a weight management or obesity conversation is so sort of in my heart, because as a naturopathic medicine student, I was working in the weight loss industry. I was working for Jenny Craig. Hands up, who remembers Jenny Craig?
Yeah.
Yep.
I think I'm a lifetime member. Carry on.
So back in the day, I was a consultant at Jenny Craig, and I learned so much through that process from the people I worked with, both my colleagues and the ladies and men that came along. I learned about habit forming. I learned about the struggles with managing our weight. I also learned how bad food can taste. Because the Jenny Craig food was not known for tasting particularly good. That's why they lost weight. Yeah, no. It was an interesting experience, that's for sure. And one of the things I really saw was people who did really well, they applied their discipline, they stuck to a program that was guided for them, but then they would sometimes come back 6 months later. And I'd think, what a shame that person has, gone through that weight cycle that so many people do. And I thought maybe just by show of hands, and no pressure tonight, if you don't feel like sharing, we are recording tonight, but the camera is on the panel, so it's not on you as attendees. So if you don't want to share tonight, please don't. But I thought just, raise your hand if you've ever been on that weight cycle, if you've ever lost weight and then found it somewhere again. I know I have, yeah. I lost 20 kilos, gained half of it back and had to try all again. It's so common, isn't it? And who's ever started, thought, I'll start a diet. I've heard that this diet is the right thing, whether it's the carnivore or vegan or whatever it is. Who's started something and not carried it through? Yeah, definitely me. There's so much out there, isn't there? And I think it can be really confusing. So tonight, part of our intention is to take what is available, that knowledge that's out there, that conversation about ketogenic diets and different types of ways of living and eating, and is it all about protein? Is it not? We'll talk about injectables and weight loss medications as well. There's so much that I know you'll have on your mind, and I'd really love for you all to share and ask those questions that you have. And of course, when it comes to weight and metabolic health, there's not a one-size-fits-all. There's lots of different viewpoints and different ways of managing things, and that's why it's so great to have 3 different modalities here tonight, 3 different viewpoints, and we can capture everything. So let's kick off by introducing our wonderful panel. So let's start with Jane. Jane Mangini is a clinical nutritionist and recently qualified in sports nutrition, which is an area of her interest. So Jane has a passion for helping people to create really good habits. She's great at helping you with practical tips in the kitchen and movement as well, exercise and movement. If I can come to Alexandra next. Yes. Alex or Alexandra is our registered counsellor. So Alex draws on a range of evidence-based therapies. EMDR is one of Alex's treatment processes, cognitive behavioural therapy, and lots of various training elements that she brings to her work in psychology. So we can pick her brains on the psychology of what we go through with weight loss. And Dr. Mark Mellor. There's a long list of Dr. Mark's qualifications.
Summarise.
He's a fellow of the RACGP, postgraduate diploma in obesity, so a GP with a special interest in obesity management. And just this year, Mark was actually awarded a recognition of extended skills in obesity management by the RACGP, and he serves as the state lead for RACGP Obesity Specific Interest Group, which is where they do healthcare for education for other healthcare practitioners in that area. So I thought we might start by handing over to you, Mark. How does that sound? So tell us, how do you define obesity? What is obesity and weight issues about? And maybe if you can also lead into some of the healthcare trends that we're seeing at the moment in Australia.
I think the first thing I want to say is welcome to everybody and thanks for coming, because I think it's actually a really difficult thing to talk about weight management, to talk about obesity. Can everyone hear me, by the way? Can you hear me okay at the back? Yeah. I can't quite see you because of that big light. So if I'm not quite looking in that direction, it's because I'm being blinded. It's a difficult thing to talk about, isn't it? And I think part of that is because for decades, the narrative in society is that obesity has always been a choice. So it's something that people choose, and they can choose to get themselves out of that problem by eating less, exercising more. So that's always been the mantra. And you only have to look to media portrayals of people with obesity. Homer Simpson, they're portrayed as being a bit stupid, a bit thick. And we buy into that. And we've done that for decades and decades. And it's because we've never really understood the clinical aspects, the biological aspects of obesity. And actually, we recognise that it is a chronic disease process. It's not a choice. And if it was a choice, I don't think we'd have 2/3 of adult Australians with either overweight or obesity. And we all put our hand up, I think. We've all tried to diet, we've all tried to lose weight, those of us that are affected. And what we find is actually when we've got bags and bags and bags of willpower, we can lose weight, we can lose some weight, but we then tend to put it back on. And that's not a choice, it's not failure. Society's good at blaming us for that and saying, well, you failed that diet, you failed this program. And the problem with that is then the person living with obesity buys into that blame and feels they are responsible. And that, of course, just adds to the whole weight cycle issue. So we understand obesity now as being a clinical problem, a disease process, and there's really clear evidence about that. And the point about that is that it then leads into treatment, safe and effective treatment. So there are effective treatments out there now. But the first step is helping just to empower people that are living with obesity to actually come in and have those conversations with a GP, clinician, nutritionist, whoever. So that, I think, is, if there was a take-home message, it would be that there's heaps of obesity, bias and stigma out there, and people living with it are often great at blaming themselves as well. And almost the first step in treatment for me is helping people just to recognise their weight issue as being separate from them. They are a person with obesity, not an obese person, and I would never refer to somebody as being obese. It's person first, and we need to recognise it as a chronic, at least a chronic condition, but there's a good argument to say that it's a chronic disease process. Now, the determinants, if you like, for obesity, the things that drive it, are also largely beyond the choice of the individual. Genetics, certainly, that's hugely important. We know that people that are living with obesity are much more likely to have the genes that we've discovered that drive weight gain and serve to maintain that higher weight. But it's also more complex than that. There are social determinants, job, work, stress, relationships, all those sorts of things. Our relationship with food, nutrition, obviously is really important, activity, and psychology, our mental health. That's really, really key. And I don't think there's a single person I see as a clinician that doesn't have some emotional or psychological background to their weight issue. So these are really important things that as clinicians we need to really pick up on. So back to your question, I think, which was, what's the definition? How do you define obesity? Well, look, the first thing to say is, what is obesity? And I think that term in itself sometimes can be stigmatising, because it's been used, hasn't it, to blame and shame in the past, but it is a clinical term. But really what we're talking about here is a condition of excess body fat. And body fat, remember, is important. It serves a purpose for us. It protects us, it cushions us, it retains heat. And it also, in a sense, regulates our appetite and our metabolism to a degree. But there's a point where sometimes that excess body fat can actually become a problem for us. It can start to cause health impairments. And that's where the issue is for people with obesity. It's not just because of living in a larger body and having excess body fat. It's because of the health impairment that goes along with living in that larger body, having that excess body fat. Now, body fat that's around the arms, around the legs, around the buttocks, generally speaking, doesn't cause us too much of a problem, other than the fact that if you do have a lot of it, then it causes a pressure effect on the body. It can affect mobility, cause strain on joints and things like that. So that's really important. But it's the fat around the middle that tends to cause us problems, what we call visceral fat. So you may be aware of that term. And the reason it's a problem is because there comes a point where that fat isn't just sitting there inert, not doing anything. It's actually harbouring inflammatory cells that cause all sorts of havoc. And other issues with visceral fat, that it dysregulates our appetite, and it can lead to problems with the way we eat, what we eat, how we feel in terms of hunger, and how we feel in terms of satiety, feeling of fullness. And that's where we start to get problems. So if we look at what sort of health problems people can experience, we're thinking about cardiovascular diseases, so stroke, heart disease. We're thinking about things like fatty liver disease, kidney disease, dementia, cancer. There's about 200 conditions that are direct consequences of obesity. And we're starting to use a term called clinical obesity, which is recognition that some people living with excess fat are actually living with an illness. So that's a person's experience of that disease, if you like. And those people need help. They need support. They need treatment. And one issue we have in Australia is that we have no equitable access to effective and safe treatments for obesity. Well, that is something we're working on, and one of my roles in the RACGP specific interest group is advocating for access. So we actually have a meeting, our second meeting with the Department of Health next week, to really try and get this on the agenda. I mean, it is on the agenda for the government, but they just don't quite know how to fund it because it's expensive. But they do want equitable access to treatment. There's a national obesity strategy, and we're almost halfway through that. It's a 10-year strategy, and we need to get treatment, funded treatment, for people who want it and people who need it. So back to your definition, which I still haven't answered after a 10
I knew you were coming to it, don't worry.
There's different ways to define it. Of course, we use things like body mass index, but we know that whilst that's kind of a good population level measure, it doesn't really tell us about the distribution of fat. And as I alluded to, it's the fat around the waist that's the problem. So really, a tape measure to measure waist circumference is probably the best way of actually diagnosing it. But what's important isn't just diagnosing the condition of excess body fat, it's looking for the health impairments, because this really is about improving health, isn't it? It's about health gain, not buying into social desire for thinness. It's none of those things, and I think we all appreciate that. It's about improving health. So we need to look for the health impairments associated with obesity, and then think about how best to treat it. And a phrase you alluded to is there's no single one-size-fits-all approach to this. It's certainly not as simple as a medication or an injection. That could be part of your treatment, but it's much more than that. And that's why we work as a multidisciplinary team with treatments around nutrition, activity, but sleep, mental well-being. These are all really important aspects of treatment as well.
Yeah, it's really good points that you make. And I certainly see, as a naturopathic medicine practitioner, a lot of people present, or they come in first up because their symptoms are fatigue or difficulty with mental focus or brain fog, or they think maybe there's problems with their hormones, they're just unsure, there's a feeling of unwellness. And sometimes cardiovascular can come into that. And so I think when we see that, it's it's definitely possible, and certainly when we do we lift the hood of the car, as I call it, and do some functional medicine testing. It might be microbiome testing or looking at genetics or whatever else is relevant to that person. We often see that there's a metabolic component to what's going on. It's a contributing factor, maybe not the whole thing, but it's a contributing factor to why that fatigue and those things are presenting to start with. So fascinating, thank you. So with that in mind, this sort of holistic view of, there's so many facets of people having excess fat. I wonder, Jane, if we can lean into the nutrition a little bit, and if you can share with us, how do you individualise that? How do you move away from the Jenny Craig one-size-fits-all, plan to individualising it for the person?
Terrific, because I've done so many of these programs and plans myself, in my history as well. And we get excited and we're like, right, I'm going to start my program tomorrow. I'm going to buy this thing online or this book, or my girlfriend does this, and then your momentum leaves. So it's definitely first and foremost accountability. I feel like when you've got support, and it's a marathon, it's not a sprint, it's got to be a lifestyle change. And we hear that word thrown around a lot, but I can't remember what the question was. So
individualising, personalising the program.
So individualising, and everyone is so different. And so that online program that you purchased for $149, it's not going to suit everyone. Some people really don't like to cook or find it really difficult or don't have a setup. They might be travelling for work or living in a shared house or don't have the skills. So there's that. Some people honestly don't know what to eat, and there is so much information on the interwebs now, people screaming about this and that and this and that. You really don't, bread's good, no it's not, gluten, no it's not, should I eat oats, oat milk, oh my gosh, vegetables, no, carnivore, it's so confusing. And I think, I really enjoy working with individuals on, tell me what you love to eat, tell me when you feel your best, and tell me when things have worked well. And then we incorporate a personalised plan around that, and some people want to be cooking everything from scratch in their Thermomix and from their garden. Yes, that's fantastic. But then other people, I will buy the frozen vegetables, just eat them. It doesn't matter. So it's all got to be really individualised. And I also think it's important to set people up, and I've been on plans myself where I've eaten the same thing for 6 weeks in a row every night and literally not being able to swallow it in the end because, no one wants to eat like that. So it's got to be about what can I do that's responsible and good now that I'm going to, we all have to make a few sacrifices, but semi-enjoy that I will be able to do going forward. It's not something I can just do for 6 weeks and then, thank God that's over, and then we know what happens next. So it's really got to be very personalised and individual.
But I think on that, it's also about being a little bit flexible. So, sticking to it, say, 80% of the time.
Absolutely.
And then having that cognitive flexibility that, on the 20%, it's not necessarily about judging myself or feeling bad or giving yourself that all or nothing sort of, I'm a failure, let's give up. It's actually about getting curious and saying, well, what actually happened in that 20%? Because that actually might be an opportunity to learn and adopt and grow from that. So,
for sure.
Yeah.
Absolutely.
And Alex, while we're thinking of that, how does our mental health come into when we're thinking about behaviour change and new habits?
Yeah, I mean, it's very complex. It is very much related. It's kind of like bi-directional because we know what we eat obviously impacts how we feel and our mental health, but then we also know that sometimes it's our relationship with food that also is probably feeding some of our mental health or our... we know when we feel stressed that, it might tend to be making poor food choices, or we might tend to, not eat sometimes, or we know anxiety often starts to, for some people it might be ruminating in the stomach, so we tend not to eat, or it might interfere with our eating practices. So it really just is about examining what is your relationship with food, what is it giving you, because often sometimes, we are unconsciously eating without even knowing it. So it's about getting curious and actually understanding, well, what is my relationship with food? What's it giving me? Because sometimes it's just a coping tool to regulate, to soothe. So it's about understanding what's the relationship and then what can I replace it with to maybe get to the root cause. So, if I am feeling sad or if I am feeling happy, rather than actually eating, maybe I need to address the underlying need rather than eating just because of the emotion that's presenting.
Yeah, fantastic. I had a really great example of a lady I've been working with for a while now. She first came to me about a year ago wanting to lose weight. She's a lady in her late 50s, postmenopausal, hormones, thyroid issues. We've worked through a lot. We've worked through microbiome issues. She no longer has the reflux and that sort of thing. But she really had this mindset. She'd been actually a dancer, a ballerina in her youth. And so she really had this mindset. We were talking about it earlier, this sort of thinness mindset of needing to be thin in order to be acceptable and okay. And I just didn't even go really near that, I have to be honest, to start with. We really made it all about her health and measured some of her health parameters. And I just had a chat with her this week, and she'd just been away on a 2-week holiday with her sister in Fiji, and I was, before she went, she was talking about having to wear a bikini and being worried about, being exposed. But we've just been working on stress over the last few months, and when we had a chat, she said, I felt great. I didn't worry about what I was eating. I wasn't concerned about what people thought of me. I had a great time with my sister and really connected with my sister because her focus had just changed. Over that year, her mentality, her mindset had moved from what am I eating and why and how do I eat less in order to be thin to I'm so much healthier now. I no longer have the reflux problems. I'm sleeping better. I don't feel as stressed. And that, as a health outcome, is leading her to exactly where she wants to be.
I'm more than just a number.
Happy,
yeah,
exactly.
And that reset of the mindset.
Yeah. But coming back, if I can circle back, Mark, you mentioned that, these weight loss injections, and I'm sure many of us in the room have got questions about those because they're out there. There's a lot of questions coming up. Are they appropriate? Who are they appropriate for? And if you're happy to share, are there people they're not appropriate for? Are there times where you just wouldn't prescribe them?
Yeah, so thanks for the question. I think, would medicines like Ozempic, they're almost a household name now, aren't they? There's few people that don't know that word, Ozempic. So perhaps just to put that into perspective, for the last 3-4 years, we've had a range of medications licensed by the TGA, the Therapeutic Goods Administration, for chronic weight management. And there are some criteria there. So when we think about weight management, really what we're getting at there is obesity treatment. So weight management is one aspect. And it's important, of course, but it's only one metric. We've talked about nutrition and activity and sleep and mental health. Those are all other aspects as well. But these are licensed treatments and there are indications. And again, it's back to the body mass index, which isn't a great measure, but most of these medicines that we have, the injectables that we use for obesity treatment, are for people with a body mass index over 27 with a weight-related health impairment, or a body mass index over 30 with or without a weight-related health impairment. So those are the criteria, and if we are prescribing those treatments within those criteria, then we are using the medicine in a sense appropriately. But of course there are people with obesity that don't quite fit those criteria, and a good example would be people from South Asia, for example. They have a different, what we would call phenotype. They carry weight differently. So people from South Asia will have a different threshold for what we might consider to be normal weight, if there is such a thing, overweight or obesity. So we have to be mindful about that. I think we also have to be mindful of the pursuit of thinness for reasons other than health. Again, back to those dominant cultural narratives and what we perceive through media. These are obesity treatments, and I think that's where the focus needs to be. So those are the criteria. You asked, are there people in whom these might not be appropriate? And I think we need to probably just judge that on a case-by-case basis. But if a person's living with obesity and there are health impairments, including also mental health impairments, not just the metabolic things, the cardiology things, then I think we need to have that discussion. Are they safe? Yes, they are safe. That's why they're licensed. That doesn't mean there aren't potentially problems with them. there can be side effects, and some of those side effects can be significant. But that's why it's important to see somebody that understands obesity, understands weight management, and is able to advise you properly. I think the really important thing about these treatments is they are not a kickstart. They're a treatment for obesity, and if we accept that obesity is a chronic condition and we consider the need to use these medicines long term, then we need to be advising our patients that these are long-term treatments, not 3 months of treatment, 6 months of treatment. Are they lifelong? I think that's difficult to say because we just don't have quite the data yet of using these over that length of time. But if we look at other chronic diseases like diabetes, heart conditions, if we treat those for 3 months or 6 months, we know that they come back, and it's the same with obesity. And actually the data there is really clear for these medicines in the short term at least, that if people use these medicines for a period of time and then stop, they generally will regain their weight. So my job as a clinician isn't to think too much about getting weight loss to start, because I think we can do that, generally speaking, through nutrition and activity and things like that. But it's where are you going to be in a year, 2 years, 5 years? And I think that's my job to really think about that. Because what we don't want to be doing is weight cycling, where people use these medicines for a short period of time, lose their fat mass, but also lose a bit of muscle mass as well. That goes hand in hand with weight loss, by whichever means, whether it's medication, whether it's behaviour change or whatever it might be, even surgery. But if you then stop your treatment, generally you will regain your fat mass much more readily than you'll regain muscle mass, right? It's hard to build muscle, isn't it? It takes a lot of effort and activity, protein and things like that. So we can leave people worse off with a higher fat mass and potentially a lower muscle mass. And we need to be really mindful of that, because muscle is important. It's metabolically active. It's it drives our metabolism. We need it for function and for strength, and of course it's important for the older age group as well, who are more susceptible to the effects of reduced muscle mass. So I think we have to be cautious. I think cautious also, not about the use of them, but that we aren't buying into the glow of these medicines, because there is a lot of glow. But on their own, they are just a tool to help increase the feelings of fullness, so people can achieve that energy deficit to burn their internal fat and achieve weight loss. So what we shouldn't be doing is prescribing a medicine and then leaving our patients to navigate the rest of their obesity care. Nutrition is really important, activity is really important, and mental health.
Great. Love it. Absolutely love it. Can I open it up to questions from anyone in the room? Does anyone have a question for any of our illustrious panel? I've got more questions if you don't, but if you do, I wanted you to have the opportunity.
And yeah,
There's a question
Can we
about
just say something about some of the side effects that we find that some people get with the injectable?
So the way these medicines work, as I alluded to, is predominantly by increasing satiety, that feeling of fullness. And what that enables is you to eat smaller portions and go longer between meals. So what we're looking to achieve is that continuous calorie restriction for weight loss. That's the aim. Now, what they also do is they slow down the emptying of our stomachs. So food moves more slowly through our digestive tracts. And that's where most of the side effects sit. We know 1 in 3 people, for example, using medicines like Wegovy and Manjaro that you may have heard of, they can feel nausea. Maybe 1 in 5 diarrhea or constipation. So it's one of those drugs that can cause either constipation or diarrhea, sometimes both together. There can be some serious side effects, albeit rare, pancreatitis, inflammation of the pancreas, but that is a serious side effect potentially. It's about 1 in 500 to 1 in 1,000 people. And perhaps the other thing to consider here is that if I look at my patient base, most of my patients are sort of females 35 to sort of 55. And of course, some of those patients are potentially at risk of pregnancy. And we have to be mindful that these treatments are a category D drug for pregnancy. In other words, they're known to cause fetal malformations. But also, we have people living with obesity, which really impacts on their fertility. So they may have struggled to conceive in the past, and then suddenly they treat their obesity and find actually they become a lot more fertile. So we need to be really mindful with our female patients that are fertile, that actually you really don't want to be getting pregnant on these treatments. And also the same applies to breastfeeding as well. So we have to be cautious about that, because I do get a lot of female patients that want to improve their health with a view to conceiving, and that's understandable. But we can't use these during pregnancy, and we shouldn't really be using them at all if a person's trying to conceive. So we need to navigate that carefully. And particularly for those people that have been on treatment and are now actually thinking about conceiving. So menopause is complex, isn't it? It's really complex, actually, and people's experience of menopause can be very different in terms of the symptoms and the impact it has. And if we have obesity there as well, then actually we've got a very complex situation. To answer your question directly, I'm not aware of any impacts of these treatments directly on menopause in terms of that loss of estrogen and progesterone. And there's no good evidence to show that using these treatments has an adverse effect, specifically in that regard. Treatments, and that's what they're licensed for. So they're not menopausal treatments, but we do see people, of course, presenting to clinic that are seeing weight gain and that redistribution of body fat because they are going through menopause. But these are obesity treatments very specifically.
And I guess if I can sort of share for you, naturopathically, we often see that when we address the hormonal impact of the perimenopausal stage, we talk about liver health, detoxification, and actually address the hormonal balance, that addressing obesity can be a side benefit, if you like. So it can kind of be, it can be a little bit of both. Yeah. I wondered, does anyone else have questions at this stage? Please feel free to just butt in or put your hand up if you do. I wondered, Alex, if you had thoughts on the obesity drugs, or is there discussion in the psychological world around the impact of, body image around the medications that are so common now?
Look, I'm going to let Mark talk to any of the GLP-1 drugs, because I haven't had much experience with that with my own client base, but I think body image is a huge thing, because it's obviously, how we feel, how we perceive ourselves, and obviously with a lot of people it can be positive, but it also can be very negative. And often a lot of this conditioning around how we should look is, I think Mark sort of alluded to before, there's a lot of messages that we receive in a day through pop culture, dieting culture, fitness culture, what we see on social media, what we read about in the news, but often stems also back from our family of origin, maybe messages we heard from mum and dad about how we should look, and then it also feeds into, how we seek validation. So what does body image actually mean to us? So, Brené Brown, I think, does some fabulous work around, what are the measures of worth, and trying to get our mind to sort of reset to say, look, well, body image, it might be one aspect of my worth, but there's lots of other wonderful things that I find is a measure for me. So it's also, I think, about that mind shift around, okay, so, I'm more than just my body. I'm more than just my accomplishments. I'm more than just everything externally. It's actually what's inside that counts. But
that's really important, actually. And I think back to that phrase before about just some of the language we use around obesity. People are not obese, they're people with obesity. And I think one thing I try and tease out early on is that you are a person first, and we some people can sort of overvalue, in a sense, their obesity issue. In other words, can blame all of their problems on obesity, and if only I can lose weight, all those problems will go away. And actually, what we're doing is we're treating obesity, the fat mass bit of this, if you like, but still other problems can exist. And I think we need to help people sometimes to really learn to love themselves as they are first, almost before we embark upon treatment, but certainly in tandem, because I have had patients lose stacks of weight but still are just as unhappy and actually realise, actually it's not, the obesity was an issue, but I'm treating that, but still there's other issues, my relationship, my work and things like that. Do you find that that's
definitely, because I think the body image can be such a source of shame for a lot of people, where it's really about investigating what is that, what does it mean to them, because like you said, we've addressed that issue, but then what's going on for us. So I mean, there can be so many different things going on there, but I guess it's I'm just trying to think where to go on that, because the question's so big.
It's a big question, and I think what's also important here is that you have time with your clinician, and that's why we have long appointments here, because you can't do this in 10 minutes. There's too many facets, there's too much to it, and I think we'll do a disservice to our patients if we try and cover everything in 10 minutes and then prescription for some medication. We really need to be thinking about our patients' journey, where they've come from, what their goals are, what their health goals are, and these factors come into this. Are there underlying mental health issues, disordered eating, stress, emotional eating disorder, that's prevalent, binge eating disorder in obesity clinics, and we need to be managing those conditions in their own right. Not necessarily first, it can go in tandem with weight management, but these are really important facets of treatment that we can miss in short appointments and without the team around us. I'm not a counsellor, I'm not a nutritionist, and it's really important we have these components to the team so that patients can manage those issues.
And that root cause analysis, so once we've addressed the weight issue, or what's actually going on underneath that's causing you to still feel the way you do.
Yeah. So you're still buying size 18s when you lost all that weight 25 years ago. I have another question, and this is a little bit different. So moving away a little bit from medication for people experiencing obesity, what about fasting? And maybe this is one for you, Jane, because it's a question I hear quite a lot. There's different types of fast, water fasts, juice fasts, even carnivore diets are a type of fast, intermittent fasting. Are there fasts that you like to recommend and don't recommend?
Yeah, sure.
Or are they suitable for some people but not others?
Yes, I would say predominantly they work better for men just because of hormones. For women, particularly perimenopause, menopause, it stops working. It just, when the body says, I've got no food and I'm going to starve, it just puts the body under stress, and you're not going to lose weight when you're under stress. So that's the first thing. The only fasting I'm interested in is when you're on the couch at night, just stop eating. Easier said than done. And then don't eat until you have breakfast. And that's just time-restricted eating rather than fasting, and that works really well. The other thing I find, there was a couple of points I'm just going to bang on a little, is yes, when we lose weight, we lose muscle, but it doesn't necessarily have to be so dramatic or that way inclined. Just a personal story. A couple of years ago, I was struggling with perimenopause, and I joined this gym in Perth. I'd come back from Sydney, and I did this, challenge at the gym, and that's where I was eating the fish. Anyway, so my coach put me on strength resistance training, which I'd done obviously all my life, but not really as intensive, and I went 5 days a week and I was lifting really heavy, and then he based my meals around protein, right? So I had to have protein straight after the gym, protein mid-morning, I had lunch, I had dinner, and then I had some sort of proteiny snack, after dinner. And I literally could barely eat my way through it, but it was calorie control, because you're never really going to lose weight if you're eating too many calories. I mean, that's that. And I actually lost, and I can't remember the details, but I know within the 6 months I put on 2 kilos of muscle, but I had lost 8 kilos of fat. So my weight only looked like 6 kilos lost, but my whole body shape changed. So I lost weight, but mainly I lost fat, but I didn't lose muscle, I actually gained muscle. So that's why it's so important to not starve yourself in the morning, because that's just a way of eating less. And then what happens in the afternoon and the evening? Doesn't it? Because your body is searching for nutrients.
And you've started the day on cortisol.
Yeah, and you're jacked up, and guess what? And I can cut and paste a lot of what, women particularly come and see me, and they're like, you know what, I just met menopause, and I'm like, yep, tell me about it. And I could literally cut and paste what habits we get into. You know, we've still got kids at home. We've got ageing parents that, you know, there's a lot of dramas there as well. We still have careers. We're stressed, and people are chugging down the coffee on an empty stomach. Then they're going to fast, and then they go ballistic for the rest of the day, and they're not having quality protein, so they're not building muscle, and then our metabolism slows down, and then, you know, we self-medicate with food and some drinks because, you know, we've maybe got more money than we've had, and we don't clean our own houses anymore, or do our own garden like we did in our 20s. You know, we've now got a cleaner, we've got a gardener, we're not lifting kids up, and we're having a bit of a relax, and we're going out to dinner with a husband, and, you know, and we're having a glass of wine. And so these habits sort of sneak up, and sometimes, you know, when they come and see me and we actually chat it through, I mean, I don't tell them, but they're like, yeah, this is actually not good, is it? And I'll be like, there you go. And so what I want to say is food, nutrition, timing of nutrition, not about fasting, but, you know, being responsible and accountable for what you eat and when you eat it is really important. And I could talk about muscle and protein as a thing, as a priority mainly, and that's really important.
I think just picking up on that as well, actually, if we look at the evidence, the research around this, there is no diet that's superior to any other diet, if you like. We've got 20, 30 eponymous diets with different names, DASH, keto, carnivore, you mentioned all these things.
Macrobiotic used to be the thing.
So there's no superior diet except for, as Jane mentioned, what is key is a continuous calorie deficit to lose weight. That's the only way you do that. But the challenge with that is, of course, is ensuring that there isn't a protein deficiency or other macronutrient deficiency or a micronutrient deficiency. We don't want people following an unhealthy approach to weight loss. So when patients speak to me about that, really, I think it's very personal. Some people come in and they enjoy fasting, and of course there's nothing wrong with that. But is it superior to having smaller portions and achieving a calorie restriction that way? Actually, there's no real evidence for that. So I think we just have to work with our patients and ensure whatever approach they're following is nutritious and isn't going to cause harm. That's really, really important. But I am wary, and I think we should all be a bit wary about those kind of front-loaded, very restrictive approaches to eating. Are you going to do that forever?
No.
Are you going to be keto forever or a carnivore forever?
Oh, no.
Healthy eating, isn't it? It's about making sure that you're eating the rainbow, high quality diet. I mean, the only real diet that showed really good evidence, one is the Mediterranean diet, not for weight loss but for cardiovascular health, and the African heritage diet, which is pretty much the same thing. So we've got to be culturally sensitive as well, make sure that we don't project things on people. It's just not going to be achievable or sustainable. And that's really key, sustainable eating. Yeah.
What about the CSIR, total wellbeing?
Yeah, so thanks for mentioning that. So that is a good approach to eating, but it is essentially a healthy approach to eating. It's high protein, low refined carbohydrate, a mix of low starch, low carbohydrate vegetables, and high quality lean protein. So keeping, fatty red meat to a minimum. Lots of fruit and nuts and things like that. But fundamentally, in a sense, it doesn't matter what you eat, as long as it's balanced. It's the portion sizes and the amount of food we eat, and snacking and discretionary foods.
And coffees.
So high fibre,
and
boredom eating, those things. Yeah. So high fibre, high protein, low refined carbohydrate, and we've not even talked about processed and ultra processed food.
We could be here all till
So
10 o'clock.
whole
Yeah.
We
seminar.
could talk about that. So healthy. A healthy whole food approach to eating, and a good measure for me is if my grandma wouldn't recognise it as food, I think I probably shouldn't eat it.
Eat as close to the natural
But
Absolutely.
you mentioned the 80-20 rule. This is not perfection, and this isn't being rigid about rules either. In fact, actually, if anything, it's really just trying to normalise appetite, because we know in obesity people have this dysregulation of appetite. So if our treatment approach is you've got to stick to this and do this and count calories and all this, you're setting a person up to fail. In fact, actually, we don't want any of that. What we want is a focus on health, well-being, and normal eating.
I saw a great meta-analysis, so meta-analysis being a study that studies studies, and They looked at all the various different diets, 30 different diet types, and their finding was the most effective diet was the one that the person felt most aligned with. That it fit their cultural fit, it fit their work routine, their family, and it just fit with the way that they lived, because they could stick with it. Because to your point, it's hard to do something and then do you continue with it? So it's something that can become a lifestyle for you, that fits for you, that works in all of your areas of your world. To sort of wrap things up, if there are no more questions, and we'll all be around at the end, because I realise this is quite a personal topic as well. You may wish to grab one of us at the end and ask personal questions. Not of us, of you. We will not answer personal questions. If I can just direct this question to each one of our panel. So what could someone do for your field? What would your advice be if they want to improve their metabolic health journey? Starting tomorrow, what's the one thing that they can do, that they can take away and start to action? Anyone?
Eat a protein-rich breakfast before 10 a.m. Bang.
Beautiful. Protein-rich breakfast before 10 a.m.
Yeah.
Boom.
I suppose as a clinician, really just being probably broader, you're not alone. Seek help. There are GPs, which are your first port of call in a sense. That's how it works, isn't it, in Australia? So there are GPs with a special interest in weight management, in obesity. You alluded to that right at the beginning, recognition of extended skills in obesity by the RACGP. So if you seek out GPs that have an interest, they'll give you time, they'll give you support, and you don't need to tread this pathway alone. People that come to my clinic, it's a very safe clinic, it's a safe space, there's no judgment, no bias, no stigma, and I think that's really important. Obesity needs a team approach.
Yeah, absolutely.
Look, I think from what piece of advice, I think get curious, adopt the scientist hat and sort of understand what is your relationship with food, but also just challenge yourself. Like, think about, what is my body image mean to me? What am I outside of my body image? And try and reset that mindset around, rather than, I need to lose weight. Well, maybe I want more energy, or maybe I want to move without pain, or maybe I want to be able to kick the footy with my son or my grandson or whatever. So trying to sort of just reshift that or reset that mindset around what does weight and body image actually mean to you.
What's your motivation for it?
Yeah.
Love it. Thank you so much to our panel for giving up your Tuesday evenings and for volunteering your time. If you wouldn't mind sticking around, I'm sure there'll be people who want to pin you down and ask you questions. And thank you all for joining us. I know on a Tuesday night, like I said, it's tricky to get you out on a cold evening, but we really appreciate you being here, and always here to help you in whatever way that we can. So we look forward to seeing more of you around. Thanks so much.
Thank you.